have some folks joining. I know we have more joining, but we'll go ahead and get started so we can start and end on time. Welcome everyone to Project Echo Geriatrics. I'm Kate Bennett, a geriatrician over at Harborview with the University of Washington, and I'm really glad to be joining all of you today for this hour. If you haven't already, please do introduce yourself in the chat, just your name and your role and where you're located. We have folks all over the state and sometimes out of state who are joining us here for this session. We're going to run this echo session like we usually do, following the echo model, which will be a short didactic at the beginning with some time for questions and discussion if there are questions that you have. And then the bulk of the session will be discussing a case. And Dr. Kim Vu, one of our geriatric medicine fellows at the University of Washington, is going to present a case. So we will talk about that all together. But we'll get started first with our talk, and we have a really great speaker who, if you've joined Echo before, if this is your first time, welcome, and if you've been here before, you've probably seen Carol Crawford. She is a pharmacist with special expertise in geriatric pharmacy and is often an Echo panelist and has been for many years on here, and we've learned a lot from her. She is the pharmacist for the medical specialties at Harborview Medical Center, including the senior care clinic. She has really broad expertise, but particular expertise in older adults. And she's going to share with us the updated Beers criteria in 2023. And if you're not familiar with the Beers criteria, you're about to be. So thanks so much, Carol.
Thank you. Yes, so I am going to review the 2023 updated Beers criteria list, and it came out in May and published in JAGS, so I'm not sure if anyone has had an opportunity to look at it, but if you haven't, then this will truly be an update for you. And just as a intro to this, for some reason, I don't know why my slides are not forwarding, so, oh, here we go. This criteria can be applied to all care settings, by the way, in the geriatric setting, barring hospice and palliative care, and they're maintained approximately every 3 years on a 3-year cycle by AGS. And there's nothing usually on each update that is like mind-blowing or like, woo, surprising. Changes are mostly fine-tuning based on new evidence or data that have occurred between the updates. And the last update was 2019. So today I'm going to provide an update on the 2023 Beers criteria, discuss how some of those information in there can be utilized in your clinical practice. So not just the updates, but some of the other things that are in there. And then hopefully provide some alternative medication options and strategies for some of the more egregious medicines that are on the list. So I did send the link to Amy on accessing this new update, but it is very easy to look up, actually. I wanted to remind everyone that there is a mobile app and pocket reference card that you can actually access through geriatricscare.online.org. And the American Geriatric Society also publishes a suite of public educational materials for our patients, caregivers, as well as providers, and that is the homepage. And I think we're all pretty familiar with health and aging. And then just for a mental or visual on how the criteria, if you're not familiar with it, it's organized. It's basically organized into tables. So the first table is medications that are generally to be avoided, period, in the elderly. Table 3 are medications that should be avoided depending on comorbidities of the patient. Table 4, drugs to be used with caution in our elderly. Table 5, drug-drug interactions, so medications that when kind of given together can be problematic and what those problems are. Table 6 is how we need to dose adjust certain medications based on CKD. And then there's the Beers criteria additional tables, And this is what I'm going to focus on today. So I was going to spend a minute on table 7, which there is no updates to this table, but it is important for us to be aware of those medications that have strong anticholinergic properties. Table 8, not going to mention at all. These are just basically, it's just a decluttering category for medications that no longer are being used in the US, so they're just being removed. Table 9, medications criteria added since 2019. Table 10, medications and criteria modified since 2019. And there were approximately 70 kind of iterations or modifications to this guide. So I'm just going to do obviously kind of changes that are pertinent, I feel, to your practice. So kind of the highlights of the update. So in the first table, medications to be avoided, things that were added since 2019. First, aspirin to be avoided for primary prevention, which I think we all are pretty well on board with. There really hasn't been shown to be a net benefit with the addition of aspirin in patients, elderly patients, for primary prevention. There was the Esprit trial that was in 2019, which looked at 19,000 elderly patients, and that kind of solidified that for us. There's quite a bit of mention about DOACs in this new updated criteria. Rivaroxaban now moved to being avoided in favor of other DOACs. Warfarin also to be avoided unless other options are not viable. And probably everyone here is using apixaban as their DOAC of choice, which is appropriate. It is the one medication of the DOACs that is least renally cleared. And at least by studies, it's a little safer from a bleed standpoint. Oral and transdermal estrogens are not to be started now, also in a postmenopausal woman. And that's due to its increase in risk of heart disease, stroke, and blood clots, with the caveat that topicals are still appropriate for symptomatic vaginal atrophy or UTI prophylaxis. And then this, we all probably know, all sulfonylureas are to be avoided in favor of the other options that are less risky from a hypoglycemic standpoint, and also can give you other benefits, not just reducing blood sugars. Caveat, though, I think, is that we still do use these medications, this class of medications, in certain patients that have money issues or restriction in money, just because they are the cheapest of the anti-diabetic medications. And they also don't cause weight loss. So some of those newer medications, unfortunately, in some of our patients, it's not ideal. Weight loss is not ideal, and they often do contribute to that. Table 4, medications to be used with caution. Ticagrelor is to be used with caution due to has been moved into this list because of its risk of increased bleed. SGLT2 inhibitors are to be used also with caution. And I did want to pause very briefly on this class, the sodium glucose cotransporter 2 inhibitors, just because there's been a lot of studies that have put them as first-line agents in nephrology, also in cardiology. So very good medications. I think the last study that looked, and they're all the flozins. So looked at empagliflozin in 2021, looked at the Emperor Preserve trial, and that actually was a great trial to show in patients that weren't even diabetic that there was a reduction in hospitalizations and mortality in those patients. So really good information and support for their use now. But in our elderly, they can be problematic. So we do need to screen. So first risk potentially with these medications is that of euglycemic diabetic ketoacidosis. So of course, most of our patients aren't on keto diets, but many of them do have very poor oral intake. So you want to be kind of assessing that prior to starting or maintaining these medicines, just so that you're not potentially putting them at risk. Genital urinary infections also are a risk with the SGLT2 inhibitors. So you want to make sure your patients don't have recurrent UTIs. And these class of medications potentially also can cause some hypotension through their mechanism of action through volume depletion. So you really want to make sure that your patients are well hydrated, that they know that you need to be well hydrated. And if they're on, for instance, a concurrent diuretic, that you might be needing to reduce the diuretic dose if you want to accommodate your SGLT2 inhibitor. Here's my little plug on that. Table 5, DDI, the drug-drug interaction table, no additions here other than skeletal muscle relaxants were added as a CNS medication group that we want to try to not combine with others. And I do have a slide a little bit later on this class of medications. I'm not sure why it wasn't, kind of clearly laid out earlier, because they can be a very concerning class of medications for our elderly. And then medications that we need to avoid based on kidney function. Baclofen was added, and it should be avoided now, recommended to be avoided in creatinine clearances of less than 60, which is most of our patients, or a good portion of our patients, I should say, due to the increase of risk of encephalopathy. And so that's kind of the one thing that was added. Baclofen, as you know, is often used for primary or first line. It is a first line agent for certain anti-spasticity disease states. The other medications that I've listed below, gabapentin, spironolactone, et cetera, are more there just because they're not additions. They've been there. They've been on the last Beers list criteria, but I do often see that they're used at creatinine clearances that they're not necessarily recommended at. So as an example, gabapentin and pregabalin, as a reminder, even at creatinine clearances of 60, you should be looking kind of at the daily dose and being cognizant of that due to its potential increased risk of CNS adverse events. And then the other medications, avoiding in less than 30 for the rationale that's listed to the right there. Okay, so table 7. This is a table that I wanted to spend a little bit of time on because it is important, I think, for us to be very aware of which medications are considered strong anticholinergic medications. And there are many of them. And so I also think that in some cases we can very easily avoid using them. So I thought I'd just spend a minute on that. So first of all, for paroxetine is this SSRI with strong anticholinergic properties. What I've put off to the left there is just the conversion table. So you don't need to cross taper if you're switching to another SSRI with less anticholinergic properties. You just need to look kind of at the equivalent dose and then switch. Easy to do. The other class is the antimuscarinics for urinary incontinence, especially urge incontinence. Mirabegron came onto the market in 2012, used to require a PA, but no longer does, and Bibegron in 2020. So these are two good options that we can use to avoid potentially this class of drugs that is highly anticholinergic and problematic. And then just to the left there, I do have just an excerpt or a chart from the JAMA 1995 study, which we don't have time to discuss, but it's just kind of reemphasis that in this particular study, it showed that behavioral modifications compared to the drug of choice at the time, which was oxybutynin, actually worked better to reduce urinary infrequency or incontinence. So just a reminder on that. Hydroxyzine, I'm pulling this out just because there has, not necessarily in the elderly, but been an uptick in the use of hydroxyzine, a highly anticholinergic medication, potentially with the thought that it's safer than some of the other ones that are used for anxiety, for instance, that potentially carry some addictive properties, but really not a safer option at all. And we do have some other options depending on the type of anxiety that a patient might be experiencing. So if it's appropriate and they can actually be connected, cognitive behavioral therapies is a viable option potentially. And of course, in this group, we know for PTSD with nightmares or sleep disorder associated anxiety, prazosin sometimes is potential viable option. And I think the patient that we're seeing today has prazosin. And then skeletal muscle relaxants. So this class of drugs, highly anticholinergic. And on the next slide, we'll talk a little bit about them, because if there is a class of drugs that, you know, I have a soapbox against, this is probably the group. So skeletal muscle relaxants, there are a number of them. The first three I won't talk too much about, because they again are used. Baclofen, for instance, is first line, dantrolene second line, used in antispasmodic spasticity, disease states like muscular sclerosis, etc. And they do work directly on the skeletal muscle at the spinal cord area. So I'm going to exclude those from this little dissertation. But the other medications, cyclobenzaprine, methocarbamol, etc., are medications typically deriving their benefit from the side effect of sedation that these medications produce. So obviously never a good idea. And there really is no data to support long-term use of these medicines. So typically in this clinic, you know, we don't prescribe them pretty well ever. Where I'm seeing them coming mostly from patients are on them, for instance, or have been on them. They're either transferring into our clinic or they're being prescribed by the ED. There is limited evidence for the supportive use of them for short-term use. Efficacy does tend to decrease over time. And we all know that anticholinergic agents have, they're worrisome from a fall standpoint, which is problematic in our elderly, always trying to avoid that, but also from a fracture risk standpoint. And they're kind of tricky. Once you start using them at a significant dose, then it really is recommended that you taper off if they've been on the medications for about a month or more. And part of the reason for this is because their chemical structure is very similar to medications that we really don't like to be using anyway. And so, when you're stopping them suddenly, then you potentially, for instance, in the case of dantrolene, precipitating a seizure, hypertension, if your structure like tizanidine is similar to clonidine. Cyclobenzaprine is actually similar to a TCA, and there are some monitoring required because we don't prescribe them very often. Oftentimes people forget that you really should be kind of looking at the potassium level in dantrolene, for instance, if they're on an ACE or an ARB concurrently. So that is my little kind of plug on not using those. And then just in general, just kind of as a summary, this is an editorial from 2019 titled Using Wisely, a reminder on how to appropriately use the American Geriatric Society's Beers list. And I wanted to just emphasize that really we're using this list as a starting point for our optimization and improving medication appropriateness in our elderly. We really want to make sure that we're reading not only just what the medicines are, but oftentimes there is a little caveat besides them, some guidance around the use. And so it's important for us to read that. The other point is that the Beers criteria is not equally applicable to all countries. So, well, it doesn't really matter to us, we're in the USA, but Europe, for instance, has their own criteria. It's called the stop and start criteria. Because they do use, there are different medications that they use with a little more frequently and with greater frequency, and they have different medications that are approved. So I think the most important takeaway point about using the Beers list, Beers criteria list, is just context. So making sure, for instance, there's certain medications that potentially would be very appropriate in your patient, or not very necessarily, but appropriate in your patient, depending on the context, that are on the list. And so we need to kind of temper the list again with our own clinical judgment. And that, I think, is all we had time for. I am providing my email address there in case there's anyone wants to reach out afterwards about, or in the future, about anything that you think I potentially can help you with from a medication standpoint. I'd love to help you help out with that. And then, of course, our evaluation survey that I'll just add there for the the whole session. Thank you.
Thank you so much, Carol. We have time for some questions or comments if anyone has a thought that came up as Carol was talking, or if anyone has any questions. Feel free to unmute, or if you cannot unmute, you could put it in the chat. I have a question while people are thinking of their questions. Carol, you know, it's not uncommon for us to see patients in our clinic who might have been on a medication for a long time that might be on this list. How have you found success in having this conversation with folks in a patient-centered way that, you know, that helps get to, you know, increasing safety without losing trust?
Yeah, I think one of the things that people say like often is, I've been on this forever and I've never had an issue. So I usually, you know, try to acknowledge that, and that because I think a lot of people, sometimes people, why they're saying that is that it's, speaking of trust, like, you don't trust me, or I you know, I'm maybe you're categorizing me in a way that I'm not in that category. So I usually just talk about, you know, just that as we age, and I just talk a little bit about how things change as we age, and things that we need, you know, priorities that need to make sure that we need, and things we need to do to maintain, you know, independence. And that oftentimes one of the big things about this criteria is just pointing at, you know, making sure patients don't fall or, you know, injure themselves and then they're hospitalized. And then oftentimes after that, you know, they lose their independence. So that's how I usually phrase things. It's just that, you know, we need to, as we get older, you know, things need to change. And this is, we're going to start to change in a way that things stay safe for you.
Thanks, Carol. That's really helpful. There's a question in the chat from Mary Pat. She's just wondering about gabapentin in particular, if you're trying to get someone down on the dose. You can comment on that. I don't know if you can see the question in the chat.
Oh, sorry. I didn't see it, but I'll look at the chat now. Do you type it down if a person was taking an inhibitor drop down to 300? So if they're being titrated from 800 to 300, yes, you should titrate down. If they were dropped like that, you know, I don't, if that's the question, Mary Pat. So the bottom line is, yes, you should be titrating down on gabapentin. You don't need to be, unlike, you know, certain medications like antidepressants or, you know, benzodiazepines, where you need to really, you know, extend the time frame and you know, and really be, you know, judicious about how you're doing it. Gabapentin is increased every 3 days. You can kind of increase the dose. So similarly, reducing dose, you can do kind of similarly go down on, because yes, it can be problematic if you don't, for the patient. They won't like it. And I think that if a person's been on 800 milligrams, and I mean, most of the patients that I know that are on substantial doses of gabapentin, you know, have want it. They like this medication. So, you know, and usually that the problem hasn't gone away. So you're going to need to, you know, kind of supply something else or suggest something else to them. Did that help, Mary Pat, or should I?
Yes, thank you so much. I think, you know, in the quote olden days, I just heard a lot more about titrating up and titrating down. And as you mentioned about antipsychotics and things like that, oftentimes for our long-term care clients, I think they're saying, they just switched me from this to this, and it can be a completely different situation. And how can we and our staff make sure that they're reminding folks if they didn't get the privilege of really talking to a pharmacist about the changes in the medication, or even with the kidney function. A lot of people are switched off medications because the new physician is doing the creatinine clearance tests and finding out, no, this is not good.
Mhm. Yeah, so.
Thank
yeah,
you.
Yeah.
Great. Well, thank you so much for this talk, Carol. It's really important to think through this for each of our patients. It's a complex discussion when you're making changes, but important to look at this list and think about it in the context of each of your patients. So I appreciate you walking us through this with the updates since things evolve over time. We very much appreciate it and for answering our questions. And thank you so much. We're going to shift over to our case discussion now. And we have Dr. Kim Boo, who's going